We'd like to first welcome everybody to Toyon University's presentation of COVID-19 funding and requirements. My name is Dave Yoder. I will be our moderator for today's session. Just a reminder that all attendees will be in a listen-only mode for the entire session. You will not be able to share your audio or video. If you do have a question for our panel, please type them into the Q&A box, which can be accessed at the Zoom ribbon on the bottom of your screen. We will pause a few times throughout the session for polling questions and to answer any questions that you may have for our panelists. As always, we encourage you to ask questions and share your comments and experience. If for some reason we're unable to address your question during the session, we will respond and follow up with you after the session. And for your reference, we will be placing a copy of this slide deck out on our website after the session, along with a recording of the session. And we'll let you know when that material is available. All right, so let's go ahead and introduce our panel. Many of you may already know our speakers for today's session, Robert Howey and Fred Fisher. Robert speaks frequently on regulatory issues around the country. He's an industry leader in the interpretation, financial analysis, and strategy for regulatory and reimbursement issues. His experience also includes specialization in organ acquisition and value-based purchasing topics. Robert is the president of the Florida chapter of HFMA and was formerly with the Mayo Clinic. Fred also speaks frequently on regulatory issues around the country. He is Toyon's practice line leader for uncompensated care recognition services. He routinely covers regulatory changes, uncompensated care, and the Medicare IPPS. Before joining Toyon, Fred was formerly with the Hospital Alliance of New Jersey. So we would like to make a few disclosures about our presentation today. First of all, the content of this session is primarily focused on hospitals and their related impacts. Naturally, this information is only current as of yesterday, May 19th. As we all know, new information is being distributed by HHS and CMS almost daily. But this is the most current information that we have. Just please know that this may change as new guidance and regulations are issued for this public health emergency. And finally, if you would like access to additional summaries or tables on these COVID-19 topics, we welcome you to visit the COVID-19 page of our firm's website, shown here. So before we get started, we would like to conduct our first polling question of the session. So go ahead and get that started here. All right. So hopefully you should see the poll on your screen. Depending on the size of your screen, you may have to use the scroll bar or extend your screen a little bit in order to see all the polling answers. But please take a moment to give your best answer. We'll leave this open for a few seconds. So we're just checking to see what most concerns you about COVID-19 funding. Is it all the documentation you're going to have to do? Is it potential recoupment of funds? Is it the fact that there's so many sources of funds you may not know what they are, where they're coming from? Maybe you're not certain how or when to apply for the funding, or potential fear of missing out. All right, we're going to go ahead and close the polling. And let me share the results. Looks like the majority of you are concerned with how to document all these related expenditures. All right. Okay. So, again, if you do have questions, I know we're just starting our presentation, but please feel free to enter them into the Q&A box, which again can be accessed on the Zoom ribbon at the bottom of your screen. All right. Thank you for participating in that poll. In today's session, we're going to be covering the following topics: COVID-19 funding and methods, attestations that are required in order for you to keep this funding, keeping track of additional pandemic-related expenses and lost revenue, and finally, potential impacts on the Medicare cost report process. So with that, I would now like to hand the presentation over to Robert.
All right, thanks, Dave, and hello to everyone out there from wherever you may be listening in. I'm assuming most of you are probably working from home, like myself and Fred and Dave, so welcome. We're going to do our best to definitely. We're going to talk about the items that are known, but there's still a lot of information that is unknown, even from HHS standpoint, related to the funding. Well, we want to provide the insight, what we've seen from based on our research and our reading, and also the insight that we've obtained from our clients and others within the industry. And we're all in the same position, and we want to be able to maximize the opportunities that are available to us, and also be compliant with the funding that we are receiving. So this first slide here, let's just talk about kind of set the stage where we were before the pandemic, or the COVID-19, and then where do we expect this to go into the future, right? So this was in the May issue of HFM magazine. The operating margins for a hospital performance around 1.7%, very anemic, right? Into 2018, due to the advancement of medicine, probably other factors too, was more of the trend of shifting from inpatient to outpatient settings, right? Whether it's out of the hospital and into more of the clinics, or even these freestanding centers, freestanding surgery centers, and so forth, right? Where do we see this going forward, even post-pandemic? We don't feel there's going to be much of a change. We're still going to be looking at more outpatient services, so margins are still going to be very thin. But then we have this issue with beds, right? To be able to react to pandemics, and pandemics aren't new to our country, but they are new for most of us, and going through this for the first time. So how do we then quickly adjust to the surge in beds, right? Is it when we have more of these temporary facilities, like with the ships and the comfort, or to with tents, or these other facilities, outpatient facilities, that we're converting into beds to handle the surge? We don't know. I think this is something that we're all going through for the first time. So the issue though is cash, right? With many hospitals, or all hospitals, postponing or canceling elective procedures, right? So cash was a significant issue. So CMS to pump cash into hospitals as quickly as possible, taking advantage of the accelerated advance payment program. Now, this was always available, but you had to meet certain criteria to request it. So if a provider had some significant cash issues, there was a specific form to request that, and then you get approval. With the changes to the accelerated program due to the COVID-19, the criteria was it's COVID-19. We're not going to be subjecting providers to meeting certain criteria. So if you want the cash, check the box, tell us how much you want, whether you want the max amount or you want smaller, lesser amount than the max amount, and then we'll get that cash to you within 10 days. So based on the information that was provided by CMS, this was actually published as to who received the advance payments. About 100 billion was released, and we have a graph that'll show that table later on. Go back to the previous slide, please. Okay, so this is not a grant, so there is going to be a payback to this, and there was some apprehension among providers as to whether or not they should go forward with this advanced payment program, especially with the current interest rate at 10% is. So the payback periods differ between whether you're a hospital or you're a non-hospital. A hospital being the acute care hospital, so your subacute would be lumped in with your other providers and supplier types. They only received a 3-month advance versus hospitals receiving a 6-month advance. Now, hospitals do have 1 year, according to the terms of the advancement, to repay that, and this will, and then the non-hospitals and suppliers will have 7 months to pay this back. Recoupment starts for all provider types after 4 months. So many of you received your advance payment in the early April timeframe. So recoupment should start beginning in the April timeframe for all of you. Unfortunately, CMS, they had suspended the advance payment program on April 26th. Now, so they're assessing the funding. They're just making sure that are the funds being directed to the appropriate sources. We have a few clients who requested the advance payments, received the approval that they would receive the advance payments, but because this all happened just prior to the suspension, I think it's happened on a Sunday, they did not receive those funds, even though they were promised those funds. So we're still closely monitoring this. They may be releasing it. They first identified as just the Part B suppliers not receiving the advance payment, but we're also seeing that the Part A hospitals have also not received their requested advance payments. Right, so the next is, what's the makeup of these advance payments of that 100 billion? So 82 billion of the 100 billion went directly to hospitals. And then the other 18 were to those non-hospitals, providers and suppliers. So there's a breakdown of where the funds were directed, most notably in the South Atlantic. So starting from Florida up to the Eastern Seaboard, and then your East North Central, which is the Mid-Atlantic. I'm sorry, the Upper Midwest with Michigan and Ohio, and then your Middle Atlantic with New York and so forth, New Jersey, receiving the bulk of those funds. So the issues with or the concerns that providers are going to have with this advanced payment program are, how do we project the volumes and going forward, right? So you've already got a 1 year, let's just say for hospitals, a 1 year advance payment, and then starting in August, you're going to show zero cash coming through, but it's going to be big because it's going to be applied the recoupment against actual claims that are being provided. So how do we best prepare for those recoupments, because it's going to be, are we going to assume that the volumes are going to be the same as what they were with respect to that advance payment, right? So CMS looked at what your last 6 months in net reimbursement was received. So will that happen again in the next 6 months? We don't know, right? So there's uncertainty surrounding that. But some of the tips that we can provide is, you definitely look at your volumes, right? Those short-term indicators, your visits, consultations, hospitalizations, case mix, payer mix, of course, because this is only being applied to your Medicare volume. There's got to be a coordination between the revenue cycle, your cash management team, accounting, as well as reimbursement, right? So we definitely have those that are in the reimbursement field the opportunity to run PSNR reports for those that have registered. And we can run detail as to how much of net reimbursement has been applied versus a certain period. So you definitely want to manage that process. Hopefully that within the time frame of 1 year that balance has been paid at some time, but there may be an instance where that balance has not been recouped in full. There will be a demand letter issued, and typically with these demand letters under the current process, that if it's not paid within 30 days, then interest applies starting with the next 30 days. The current interest rate on Medicare overpayments is roughly around 10% on simple interest. So it's 10% on the balance that has not been paid. It's not on the entire advancement, because you should be paying that back as we go. So it's an interest-free loan for either 7 months or 12 months. Now, there's other activity that's going on in legislation. There's also a lot of advocacy efforts out there with respect to these advance payments. So that the HEROES Act is still going up through the Hill, has not yet been passed. There's been discussions of turning these advance payments into grants to providers, or also extending the repayment period from, let's say, instead of 1 year now, maybe 2-3 years, or even just changing the interest rate altogether for these advance payments to maybe a 1 or 2%. Right? Still the unknown, but the current process is that you will be paying that back within 12 months or 7 months.
Hey, Robert, just to interrupt real quick, we have a question pertinent to that, what you're covering. Do we know how the payback of the Medicare advance payments are going to be? Will they be capped at 10% of your Medicare check, or are they going to recoup 100% of each reimbursement until all the funds are recouped?
No, it'll be 100% until the disbursement funds are recouped. So, for example, if you got let's say, 100 million advance payment, and your remit checks are being processed as your claims are being submitted, right? So, if you have a remit check that comes in at 300,000, which would be the normal net reimbursement, obviously the cash would be zero. So that 300,000 would then continue to reduce that $100 million debt for that. Let's just say for a hospital for the 12 months. So let's say if you got 100 million, and then we get to that 1 year time frame, so we're near, let's say, April of 2021. Now you're at you have a $2 million balance. you'll get a letter from the MAC saying, okay, we have not recouped $2 million. Please remit the $2 million in full. If you don't remit $2 million within 30 days, then simple interest would be charged at 10%. So in this case, it would be $200,000.
Thank you.
Okay, great question, because there's been apprehension about people taking this loan because of the interest rate. But again, the interest rate is not on the entire balance. It's on the balance that has not been repaid when the time period has ended for recoupment. Again, the whole goal was to influx cash into the healthcare system. And this was just one of the mechanisms to do that, and an easy mechanism. And I applaud HHS, CMS, and the MACs for turning this around really quick, given the circumstances. All right, so now let's talk about the relief funding, right? Those that don't require repayment, or at least if you accept the terms and conditions. Right, so this is the bigger pool of funds, right? We're all aware of the $100 billion that came out of the CARES Act for the Social Services Emergency Fund, and we'll get into that breakdown later. Then subsequent to this, there was a $75 billion that came out of the Paycheck Protection Program and Healthcare Enhancement Act, right? To supplement the PPP and also give $75 billion to hospitals, but HHS to this date has not provided details on how they were going to distribute this money. Everything's on a pause right now, and that's similar to what with the advanced payment program. Other relief, under the CARES Act, they deferred the sequestration. So we're estimating this to all providers about $2.8 billion. It helps, but you're just postponing it to the future, so you're still going to pay for it. And then the 20% increase to MSDRGs for COVID-19 inpatients definitely requires some coding, proper coding to put the diagnosis codes on the claim in order to receive that 20%. We haven't seen any clients yet that have received or have at least reconciled those payments to see that they are receiving that 20% increase, whether it's just on the base payment rate or is it on the entire payment, which includes the add-ons for like medical education, DISH, value-based purchasing, and so forth. And then we had the Families First Coronavirus Response Act, and that allocated $1 billion in testing for the uninsured. So in conjunction with the relief fund of the $100 billion, which is also going to cover the treatment for the uninsured, those funds are being administered through HRSA. We'll talk about that later. There was also a federal made Medicaid match increase to get some money back into the states, and plenty of other items that were happening, FEMA, hospital preparedness programs, and so forth. All right, so how these funds were received, and it was based on tax ID. And so, some systems have hundreds of tax IDs, and I think that was one of the lessons learned from this distribution is understanding how providers are set up, right? Even internally with respect to the enrollment system and their PAYCOS, where the information was being sent to, is the enrollment information up to date, which is, it's required to be updated anytime there's changes that are being made and need to be made within 30 days, to the plethora of NPIs that are really inactive, but they're still in active status in the NPES registry. So a lot of simplification that went out there, but HHS distributed the money based on the billing tax ID, because that's the singular reference. So you can have multiple provider numbers under a single tax ID. So reconciling those payments created that challenge. There was the first wave of funding tranche April the 10th. And to get money out quickly, it was based on Medicare net revenue over the past, I believe it was for a full year in calendar year 2019 or fiscal year 2019, just to get the cash out. And then providers have to attest to those terms and conditions. And there was a separate portal for that attestation. Needed the tax ID, your last 6 digits of your bank, and the exact amount of relief payment. Many of our clients did not have any issues with that first round of attestation. Now, the second tranche which was around April the 24th, was a rebalance of the 50 billion. So the first tranche was 30 billion. The next is to redistribute the 20 billion, but it's a rebalancing. And they based it on 2% of net patient revenue based on provider information. Now, the only provider information that HHS or CMS has that's current is through Medicare cost reports. Now, only providers submit Medicare cost reports, and your non-hospitals, like your physicians, your medical groups, and so forth, do not file cost reports. So they probably did not receive anything in the second, within the second tranche. And also that we've learned that there are some providers who did not complete the applicable worksheets of the Medicare cost report, which then resulted in no second funding. But that doesn't mean they're not going to receive any other funding. So there's a second attestation portal, and this is where you're going to include the information. We'll talk about it on the next slide. But what we're learning, though, is that the word is out that providers are not doing that second attestation. So if you received money under the first attestation, you need to do both the first one and the second one. Okay, so let's move on to the next slide. So under the second tranche, with the second attestation portal, again, separate link, you're going to report your revenue information. So they want to confirm the net revenue, and it may differ from what was on your cost report, because if you are a nonprofit, they want your most recent filed tax return, whether it was 2017, 18, or 19. Many providers have not even filed the 2019 tax return, so their latest is 2018, but their latest cost report may have been based on their audited financials for 2019. So there's going to be differentiation there. There is no true up with that information. It's just they want your net patient revenue. If you didn't have if you weren't required to file a tax return, such as your academic institutions and public entities, then you just submit your latest, most recent audited financial statements through the portal. They're also asking for your estimated lost revenue for both March and April of 2020, and they provide latitude for providers in determining what the amount of that lost revenue is, and they gave several examples. The best thing you want to do here is I would say a worst case scenario, but the scenario that fits your specific predicament, identifies maybe more recent trend. Where were you trending before the pandemic? Where were you trending if you're from a seasonal standpoint, where you would be in March and April, and also from a budgeting standpoint. Document this information for what you had submitted to through the portal. Confirmation, you'll just get an email confirmation from HHS. They won't they won't provide any status notification, but if they do have questions, they do have your email, because that was required as part of the portal, so they'll reach out if there are any questions. But again, no repayments, as long as you accept the terms and conditions. There are providers out there who have returned these funds, and there's options on how, and there's steps in the process on how to return those funds. And you don't have the opportunity to appeal or dispute the process. So the money that you're provided, you can't dispute it. There were providers that, because of the first tranche was based on Medicare revenue, that with the rebalancing based on net patient revenue, they received zero funds on the second tranche. Even though if the rebalancing in total would have resulted in a less amount than that first tranche, there is no repayment to that. If you're submitting the information because you didn't get a second payment, but you got a first payment, they're processing those applications in batches every Wednesday at noon. And hopefully we're starting to see some of that information being received. We're on a first come, first served basis. So as of the 14th, based on information that's published on the CDC website, only 34 of the 50 billion has been attested for. So if you haven't attested, strongly suggest you do so. This slide here is just an estimate of what we see for hospitals, to eligible hospitals, of the 100 billion. Now, not all the 100 billion has been allocated, but the known allocation that's out there of this, and for this particular table is about 72 billion, and by region. So the 12 billion for the high impact funds, and we'll talk about that later. That information is already available. We know who received the money, as well as the 10 billion in rural funds. All right, and then we'll move on to our, we have our next polling question.
Okay, thank you, Robert. Yes, so for our next polling question, I'm going to go ahead and launch the polling here real quick. Okay, you should be able to see that on your screen. Again, if you need to scroll down or extend your screen a little bit, please take a moment to give us your best answer. And so we're just curious, did you apply for and receive a payment from the Medicare Accelerated and Advanced Payment Program? Leave that open for a short while here. And we're also getting some good questions in, so we'll go through those next. All right, go ahead and close the polling. And let's see what we've got. Looks like the majority of you, about 3/4 of you, have filed and received an advance payment. Okay. So, all right, let's get to some of these questions here. A lot of questions about recoupment. So, do we know if the recoupment for the advance payments when it occurs is going to be by PTAN or by tax ID?
Yeah, so I can answer that question. It's PTAN, or commonly referred to as the CCN, your Medicare provider number. It's going to be based on your provider number, because that's how you requested the advancement. Because again, the hospital has a 6-month advance, and a non-hospital is going to have a 3-month advance.
All right. And then also regarding the advance payments, we talked about recoupment, and if it's not recouped, within a year, you might get that demand letter. The question is, can you pay in advance near the end so you don't get that letter?
That's a very good question. There is an information. This question has not been addressed by the MAC. I believe there should be an option. You can always send money back to the MAC, right? And you can tell them what it's for. But I think the best bet is, from a reconciliation standpoint, because of the process going back and forth, is just to wait till you get to that demand letter and then send in the payment. So you're basically holding on to funds interest-free until you get that demand letter.
Great. And then another question related to attestation. So our system received funds in both the first and second tranche and attested, but also received funds for the rural 10 billion. Do these funds need to be attested to as well?
Yes, but they haven't opened up a portal for that. There are terms and conditions that relate to it, and then we'll address that here. There's the slides on the attestation process.
Okay, great. And then, yes, just to answer another admin question, we will be making the slides available, and we'll probably be posting those on our webpage, so we'll let you know when those are up and available. Thank you all for the great questions.
Thanks, Dave. Thanks, Robert. Hi, everybody. This is Fred Fisher, also at Toyon. And Robert, I have to correct you. I am working from home, but today I snuck in the office. My 5-year-old, he would want to participate in this call too. I don't know if the audience would care to what he's playing on Mega Man these days. But it's very nice to talk to you. And so I'm going to talk a little bit about what Robert addressed. I mean, Robert really did a nice job there, kind of going through the process, what funds are available. What we've also had going on here at Toyon is really just breaking down the funding for a lot of different purposes. One, we're a bunch of data people over here, so we're obviously curious. The data's out there. And then we know that there's still 72 billion sitting, and we know that providers just kind of want to get an understanding of what's been out and where and what they might be able to start predicting next. Although I know that's a hard thing to say, is prediction this day and age is almost impossible. But at least, that's part of our job, to start to assess and understand the environment. So like Robert had mentioned, there's the first and second tranche of fundings that went out. This slide just kind of reiterates this, because we know that it's a touching point for hospitals, again, with questions on recoupment. My take, I've seen both I guess, perspectives on the possibility of recoupment. I think that, right off the bat, there is language in the FAQs and elsewhere on the HHS site that says this money is yours to keep, right? But then on the other side of the mouth, there is, especially with the advance payments, well, we're looking at, how this money is being spent, and we've frozen. So I understand the concern. I'm very hopeful that a recoupment will not take place. I do think, though, HHS, I should say, has shown its hand. And again, when I say shown its hand, it's not in a negative sense, kind of shown us their method, perhaps, in terms of how they might be dealing with this funding as it relates to the next round of funding that comes out, where, they're looking at what was currently received to determine, okay, now that we've kind of trued things up, how should we proceed with the next round of funding? Should providers be capped? Should providers be given more, et cetera? And that's, another reason why we're looking at the breakout of some of this funding. So what this graph is kind of just of a breakout of the general funds for those that might be curious. Robert had alluded to the amount going to hospitals and all other. Again, I just want to reiterate, this is the eligible amount. This is not the amount that that has actually been doled out to hospitals and have been attested for. If we were just to go and grab G-3 off of the Medicare cost report, which for those of you that did not file a cost report, that's essentially where you report your operating income. If we were to go and grab net patient service revenue from the HRSA data, which is where all the cost reports are maintained, and kind of pair it up with the other publicly available data we have, we could see where the money's landing. We could see where it's landing, and obviously, I mean, it fits what we're hearing with hot spots in the medical in the Mid-Atlantic and things like that. And it gives us a directional idea of where the funding is going. Bottom line, when we look at the funding, it's about $5.7 million per hospital. In the Mid-Atlantic, that number goes closer to about 8 million. In the Pacific, it still floats a little bit higher than 8 million. One thing to address, and I know there was a Kaiser Foundation article on it, is the impact of safety nets and the impact to, you're using that patient service revenue. So what does that mean? Right off the bat, you start to think about your rates, right? Well, geez, I wish if I had better rates, I would have got more money out of this deal because I would have had, more net patient service revenue. So there is inevitably, like many times in the system, unfortunately, a negative impact to the safety net system that doesn't get those more lucrative rates from private payers, and therefore the money that comes out of this distribution is going to be reflective of that. However, on the opposite side of the coin, that's day-to-day business. Someone else will say, well, yeah, I mean, we're getting paid for the history of our business, and yeah, that makes some sense. But it is something to pay attention to, and maybe a reason why there is that additional $2 billion appropriation that came out with the high impact funding. And that is a transition to the funding. So how does that work? The first thing that's notable here is the cutoff date, April 10th. Providers had to submit their COVID claims through April 10th. 395 hospitals qualified, and they essentially submitted about 70% of the total COVID admissions through April 10th. Now, I do know there's discussion about, well, how the heck do you determine, lack of testing? I mean, this is nuts, right? These admissions. How do you determine admission at this point? That's a big discussion, and I think that's one that, who knows, we might be having, for the next year or two. But what we have now is the data, right? And one thing to note about the data, and anytime there is a cutoff date, what about, we have to consider hospitals that on April the 11th had 101 patients. What about them, right? And so we know that some thoughts are going in that direction too. But we were able to, with all this funding, get an understanding of regionally and directionally how this money was appropriated. We know that per admission, it was about $77,000. And then we know, and that kind of trued up and tallied up to $10 billion for the 395 hospitals. But then there was a $2 billion dish allocation. And then people that live in the reimbursement world were immediately very interested in that. And my take on that is, if you read the HHS language, they quote that they say, I laugh because it's a simple formula using Medicare and Medicaid dish. There's nothing simple when you combine those two. I tend to believe, although I haven't proven it totally out, I got it pretty close, I think, Right now, what we tend to think is that the Medicare dish, encompassing empirical dish, uncompensated care dish, and capital dish, was used in these distributions. And I think it's important to note capital dish because almost every hospital gets capital dish, and therefore it opened up that funding. And here's that breakdown for those that are interested in kind of what we're seeing. You'll notice maybe right off the bat, hey, Fred, you have 374 hospitals, not 395. That's because of the way that provider numbers roll up into each other. I spent a lot of time. That was a manual entry, by the way. When HHS published these, they did not provide any numbers. So good old-fashioned way. It was fun. So then we're able to kind of tally up, and we have all the variables, right? So math people are going to say, okay, you're telling me that it's $77,000 per admission, and that there's a UC dish add-on. We could do the math from there. And that's what this represents. We could see, again, the Mid-Atlantic with the high concentration. You could also see what happens to the payments, right? I mean, you could break down the 129,912 admissions by region, but you could also say, okay, so what does that mean in terms of reimbursement before and after dish? And to give you some perspective there, if we look at this, I believe it's about $23 million per hospital net before dish. And then after dish, it's about $32 million per hospital. And so just some key takeaways there for us to start to further evaluate. Addressing the rural fund, another appropriation here. This one's a little bit, well, with the exception of provider types, a little bit more straightforward. Most rural critical access hospitals and rural providers are being paid a $3 million base payment. There's essentially a tiered methodology. Every $2 million, the payment to a rural hospital goes up by, I think, $1 million. Most rural hospitals have over $10 million in operating expenses. And so they are paid $3 million base plus, I think it's about a 2% add-on to operating expenses. The interesting thing there I want to talk about real quick is that, there is a piece for rural health centers. It's our understanding, just for purposes of this call, and we'll continue to vet this out, that the only rural health centers that receive the $100,000 base payment are those rural health centers that are not affiliated with the hospital. In other words, our understanding, it's the hospital's discretion and burden, I guess I could say, to allocate those monies to the rural health sites from the $3 million base payment, as opposed to if you are an independently owned rural health clinic, there's a separate allocation for you. So just breaking that down, just like we did with the others, it essentially goes down to about $3 to $5 million per hospital in just the rural health payments. But then we start looking at, okay, more money has come out of the general fund and high impact fund. That number gets pushed up a bit to $4 to $7 million. They sound like subsidy payments. These certainly aren't payments you could survive off of. And we're certainly hopeful that more relief is coming for these folks. And that's why we're continuing to assess. Speaking of assessing, we know that critical access hospitals are the most vulnerable, or one of the most vulnerable subsets dealing with this. So just wanted to isolate what they're going through right now and the funding that's being received. At the end of the day they're getting about $3.5 million per hospital. If you account all the rest of the CARES funding, it goes up marginally to $4 million per hospital. And I know that the freezing of the advanced payments is killing these hospitals. And so we're very hopeful that, some more money can be freed up for them. Go ahead, take it away there, Robert.
Okay, so I know we got a few Q&As, so we'll get to those Q&As a little bit later. But so it's just a summary here of the $100 billion, right? Just a synopsis of where we are on this situation. So $100 billion allocated. The first and second tranche of the $50 billion has been generally allocated, and then the targeted allocations for the high impact areas of the 12 and the rural providers of $10 billion, and then $400 million for Indian Health Services. So we have roughly $27.6 billion in unallocated funds. So new information just got released here also so what are they going to do with the 27.6 billion? Well, HHS just posted an alert maybe just a few minutes ago that providers need to take action by June the 3rd with respect to the general allocation, meaning that you need to accept the terms and conditions and submit your revenue information in order to be considered for an additional general allocation payment. So there still may be another general allocation, but if you have not accepted your terms or submitted your revenue, you may miss out on that general allocation. So just another note. The HRSA program for the uninsured for treating the treatment of the COVID-19 patients, that is going to be part of that 27.6 billion. So until those funds are exhausted or until they utilize those funds for another general allocation. Again, we still have that 75 billion out there as well. That was outside of the CARES Act. So moving on to the next slide here, when we talk about the HRSA's uninsured payment program. So the information is already for providers to register on that site. So if you haven't already, I strongly suggest that you enroll into this program. This is a separate payer, so it's being managed by United Health Group. So treat it as a second payer for the uninsured. So meaning that we're not going to claim this information for uncompensated care for S10. How the program works is for testing, and there's certain codes for testing. It's not all the CDC codes that are available for COVID-19, but as long as those these three diagnosis codes are included on the claim for testing services, then the payment will be received by the provider, and that payment will be at Medicare rates. The question out there is, well, what do Medicare rates relate to, right? Is this going to be the add-ons? Is it going to be geographically adjusted, like for wage index and so forth? That information has not been made known by HHS. We talked about the 20% increase for the DRG weights currently for Medicare patients. However, under the uninsured program, that increase will not be applied. On the treatment side, the primary diagnosis has to be with these two COVID-19 diagnoses. That was before or after April the 1st. So if that information is not in the primary position, then there won't be payment through the uninsured portal. Question from our clients is, well, then, what's our responsibility to check for insurance, right? So you definitely make reasonable attempts to identify that patient does not have insurance, right? They may be a past or a current patient with insurance information. But if you do submit the claims to HRSA, they're also going to do another check. So we had one where they submitted their first batch of claims of about 130 claims for the uninsured for COVID-19, and then one kickback as having insurance. So they did not receive payment on that one. Also, if you do receive payment through the HRSA program and later that the patient does have insurance for that time period of the service, for example, with your Medicaid eligible, your Medicaid pending, then you do need to return those funds back to HRSA. So you just, in this case, with any of the funding, right, we don't want to be double dipping into both programs.
Robert, if you don't mind, I just, one thing, and it's not really here in the presentation, but I would like to throw it out, and I've been tickling my brain with it, is things like empirical dish and the Medicaid day population. I don't think that those have been expressly delineated here, but certainly I could envision some crossover that folks might need to start to think about as well.
Okay.
Thank you.
Yeah. No, our tip on the bottom of that slide, follow your processes for financial assistance policies and verifying insurance status at the time the services are provided. Okay. The next program, and it came out of the CARES Act, and this is being managed by the FCC, is $200 million was allocated for telehealth funding. To date, only $38 million has been awarded. So this might be an opportunity for providers. And the eligibility is obviously going to be a healthcare provider, but it's limited to your not-for-profits and your public entities. So your private for-profit programs are not eligible for this program. This is a reimbursement program, so it's not a grant program. So you do need to document the expenses that you are submitting for reimbursement, and it's not going to cover everything. but at least it will help with a lot of the infrastructure, the equipment, the platform that you may be using, whether it's iPads or tablets and so forth. And it's not just for treatment, but it's also for monitoring. So this is another great opportunity for those, especially with patients that may be in underserved rural areas, to take advantage of this opportunity to attain such additional funding through the FCC in this program. All right, the next slide is with FEMA, and this one is most clients are treating this as the payer of last resort, right? So because we still have some unknown funding that's left out there, right? So funds that relate to specific areas covering those incremental costs for COVID-19, those expenses can be submitted to FEMA to receive some additional reimbursement. As a payer of last resort. So I was on a call earlier this morning about FEMA. So not only with FEMA, but with all these other government funding programs that are going to be audited. Now, if we recall with Hurricane Katrina back in 2004, which was devastated those Gulf Coast states, that those FEMA audits are just ended last year. So with the COVID-19 funding, which is probably 20 times more significant than what was provided during Hurricane Katrina, just imagine whether all of the providers are going to be subject to some type of scrutiny. So maintaining the documentation is going to be key, and we'll talk about that here later on in our presentation. And then with that, we have our next poll question.
All right, let me go ahead and launch this polling question. Should take just a second. All right, so hopefully all of you can see that on your screen. And we're just curious about attestations. Have you submitted your attestation forms for the receipt of any COVID-19 funding? Have you already sent it back, or maybe you're waiting, you're close to sending it back, your legal department's looking it over? Or it could be that you don't know, that could be handled by someone else. Just curious about that. We'll leave that open for another few moments. All right, I'm going to go ahead and end the polling, and I will share those results. And it looks like a little over half of you have sent back your attestations, so that's good to hear. But as Robert said, make sure you send back all of them. All right, yeah, let's get on to a couple of our questions here. We're getting more great questions. Let's see here. And a question about the appeal process. I know we haven't really gotten into that, but didn't know if either of you gentlemen had an answer to this. Is there an appeal process for a hospital that did not receive any rural funding, but added a rural health clinic in 2019, but was not on their 2018 cost report yet?
HHS was adamant that there is no appeal process with respect to the funding. So they did have to pick a point in time. And if at that point there was no rural health clinic on the cost report, then no, that would not be included. Now, I think we're going to talk about the rural health clinics, or maybe we did. So not all rural health clinics receive the funding because they may be attached to an urban hospital. Those provider-based, and HHS was specific to saying that only independent rural health clinics or rural health clinics attached to rural hospitals would be part of this funding. So if you're a provider-based rural health clinic to a rural provider, you didn't get a separate payment. It's just part of the total operating costs of the rural hospital, right? So the rural health clinic as well as the rural hospital are all included in that same Medicare cost report to determine their share of the funding. But if you're an urban hospital with a rural health clinic, there's no additional funding for that rural health clinic because it's attached to an urban provider. And again, it was at that point in time when they determined the eligibility.
Great. Regarding the targeted funds, do we know when HHS will distribute the targeted fund? We have filed and submitted the data already, but have not heard from HHS.
So it depends on what targeted fund we're talking about. Is this is this the high impact areas? So they set the threshold of 100 for those that be able to receive it. So, and they've already published a listing of those providers that will be receiving that money. So if you're on the list and haven't received it, I recommend reaching out to the HHS hotline.
Okay. And then specific to critical access hospitals, do critical access hospitals need to do a settlement estimate offsetting revenue loss for potential recoupment? In other words, if volume drops more than expense, we would expect a favorable cost settlement.
Yeah, that's a great question.
Yeah, we're gonna dovetail into some of that. One thing I'll say, just based on this discussion, and Robert, I'm sorry to cut you off, man. Did you have anything else on that?
No. I think that's a great question, and we're gonna talk about it with the impacts of the Medicare cost report in a little bit.
Just one thing, in case I don't say it later, again, just there's so much content here. Same line of thinking with like a sole community hospital or Medicare dependent. If you're, you got to think about filing for those volume decline adjustments. Now it's another type of Medicare relief payment that I don't think HHS is going to want to see overlap. But good questions on the cost report, and we are going to touch on those and certainly continue to follow up as we learn more. And with that, I'm going to move. Dave, are you okay with us moving forward, sir?
Yes, that's all we have for right now. Yes.
So this is, kind of getting. So we went through the content and the genesis of this presentation. Okay, what funding is there? What are some high-level things you need to know about the funding? And now we're kind of diving into, okay, so to get the funding and diving into, about the attestation and getting into some of the more poignant questions that are being asked. So real quick, you can see here the 6 types of attestations that are available on the HHS website. For each type of funding, you do have to attest for each. In reviewing each of them, they are all very common. They do include some very unusual language, of course. But the one thing that I'll say is a little bit different in the, I guess if you're looking for, well, what's materially different between them, there's more of a focus on duplicative payments in the high impact and in the HRSA uninsured program. Aside from that, I haven't seen too much more. We'll talk about what providers are considering the most sensitive language or things that they're paying the closest attention to avoid any payment duplication. Getting back to the collection, I think that what we've learned, one of the first things we've learned from this experience, like Robert's word, is the plethora of ID numbers that are out there, and how they kind of interact with each other. Again, I could tell you, in kind of doing the modeling here, I mean, I'm probably reflective somewhat of what folks of HHS are doing. I'm constantly having to check to see who rolls up into who, right? And, like in Manhattan, all the hospitals that got the hot spots, there are a number of hospitals that they're independent on the street, but they roll up under one provider number. So those types of efforts, I can only imagine what some of the larger health systems are going through. But here, I mean, this is a good list of, and I guess going forward, lesson learned is to, have a decision tree, a matrix, whatever, for your hospitals, so that these can be kind of grouped and understood a little bit better going forward. But certainly, I've my previous experience was all on the Medicare provider number. This, all these other numbers to me are relatively new and quite interesting. So back to, looking at the terms and conditions, what are people kind of honing in on? The first thing, and we talked about, are the quarterly reports, and we're going to dive into those later. So I'm not going to spend too much time on that, other than the fact that there's 2 central parts to those reports, one of which I think is applicable to most people on this call, and that is documentation of revenue loss. The other piece is related to the fund, the receipt and the appropriation expense of funding. The next piece that will, that folks are paying attention to, certainly out of network. And just some tips that we are hearing from providers that might help you during the public health emergency to avoid duplication of funding is to hold patient bills. Some folks are proactively even writing off co-insurance, co-pays, co-payments. And at the very least, it's always a good idea, and we're going to talk about the establishment of cost centers and codes, coding. It all, this day and age, I mean, everything comes down to coding, the delineation of payments and patients and all that. So this is just another delineation here, and a very important one, so that you're able to keep track of anybody that is a COVID patient that touches any other funding pool. The last thing I'll say, and I'll get a little bit in the weeds here, out-of-network is a category for uncompensated care reporting. So consider that if that is a category of yours. I do think that there's probably some financial assistance policy language that needs to be tweaked so that you can articulate things in a way to be reimbursed what is due to you without duplication. And here is the language. We don't have to get too far into it, and I'm going to attempt to use this highlighter. You probably saw me messing around with it earlier. But really, what we're looking at here is, CMS is HHS honing in on uncompensated care. That's what I see, right? I mean, they're really looking. So my take on this is, for future audits, certainly the S10 and uncompensated care. A lot of you on the phone probably have received an audit letter today. But we can't forget some of the other things that we talked about, like if you're a sole community hospital, you're going to apply for a volume decrease adjustment, and all sorts of other, I also kind of chimed in on Medicaid eligible patients. I'm still kind of teetering with that, to be honest with you, but I do think it's something that should be considered. And again, it goes back to the ability to identify and document within your systems so that future delineation is easier for you. So, getting into the reporting of revenue loss, we have a couple slides on this. I'm not going to spend a tremendous amount of time on this slide, other than I think that, again, folks are certainly looking at revenue, lost revenue, right? We know that ambulatory or elective surgeries have gone away, and some states are opening slower than others, right? And all that needs to be considered. Payer mix, though, certainly consideration. I mean, I'll tell you guys that, when the IPPS rule for 2021 came out, I don't know, last Friday, we model those, annual payments here, and I had no idea what to put in for discharges and case mix index. I mean, we're in such unprecedented times with that. And so thinking about that, again, going back to earlier comments of short-term indicators and things to help us get a good understanding of the marketplace. But that needs to be considered, right? The payer mix, what you're being affected by in terms of who's in a bed at your hospital. And then there's all sorts of other things to consider, which we have here as a resource for you. I also think just in terms of recommendations, collaboration is so key right now, obviously, but it spans outside of finance, it spans outside of PFS, it spans to really those that are talking to patients that are out there getting an understanding of, people that have necessary procedures that they're looking to have done, and really just taking the temperature of the world, which is easier said than done, most definitely. But the other thing I think is important here too is standard templates, right? As we all move forward in collection and documentation of this, it is so important that we're all collecting and documenting, caveating, whatever you want to say, the information consistently. That would make, Robert made a great reference to the FEMA audits just ending. We're thinking ahead about the expedition of those types of things and the ability to be smarter on this go around using systems and things that maybe were not in place then. Sorry, guys, toggling between screens here. So in the nitty, getting down further into net patient service revenue. So we have to look at, what are they collecting? Why are they collecting it? So the first question, they want an understanding of your usual operations, revenue loss, and then, to understand your entity, tax forms and things. Because like I say, even pulling a 990, which are public, getting an understanding of who rolls up into that, and it's very, very difficult to do. So providers are helping with that process. This is a part of the application process, right? So the submission of this information, which is due, we'll talk about in a second, July 10th, is going to be used as part of the way in which to approve. And also, as Robert just indicated with his real-time news, we need a ticker, by the way, Robert, on our presentation.
All right.
That there's more money that's looking to be doled out. So it's, the delivery of this information certainly is important. I think that the main thing I want to hit on here, again, we talked about that the reports are due on July 10th, which is essentially 10 days after the June 30 close of the quarter. Only if you received more than $150,000 of funding. Again, for many folks here, those reports are primarily going to be driven off of the quantification of lost revenue. So how do we do that? What we want to talk to you about today is, yeah, there are some recommendations from HHS about year-over-year budgets, actual to budgeted, those types of things. But there's also a lot of hybrid methodologies that need to be discussed depending on the unique circumstance of your hospitals. So what, also, before we get into that, what else goes into those reports? Well, how are you using your funding and expenses, right? So again, with these quarterly reports, not only do we need to delineate revenue loss and how that's being quantified, but how much money have the hospitals received and how are those monies being received? Through the FAQs and other means, mostly in the FAQs that HHS has out there. They're pretty thorough in terms of what's needed, and so we've listed those key points here. But the most important is your revenue reporting. And so again, there are some standard ways of reporting this information, but we do think it's important to consider some of the hybrid methods that are unique to your hospital. And so, for multi-state hospitals, as I just said, some states are opening a little slower than others, right? So some hospitals might start to see inclines in some elective procedures in other areas. There are other staffing considerations. There are ramp-up considerations. There are all sorts of things to consider as you start to think about, well, what really happened this year to us? And what are the costs that we really need to consider? Not just what was it like last year. This year was so much different. And I think that a consideration of those costs and a schedule is certainly to the benefit of hospitals. A lot of that is dependent on, and what we're hearing from the industry is the development of new cost centers, new departments. And so what we're really talking about and showing here is, well, what does that look like, right? When you're setting up a new department, what needs to be considered? There's also some obstacles, right? Because the hospital already exists. You're tacking on, patchwork system, as sometimes it's said. But the thing, what we're showing here is we have some basic patient care costs, right? But just like a cost report, we have overhead. In fact, through talking with many providers, at least in the month of April and into May, people were working 95 to 100% of their time in finance on COVID. And so all those things, I think, need to be considered when we talk about, well, what was the cost that we've incurred, right? It's almost like doing a step-down level cost report. Okay, we have our core costs, our ancillary costs. We also have our overhead. And the establishment, the ability to tag those costs with payer codes and other things, with using systems, maybe like your payroll system to help, will help with some of the appropriations that eventually will need to occur with audit. And so these are some considerations that need to be made with things like that too, is what about an emergency department? How would you create a new COVID department as an extension to the emergency department? That's a big one, right? A big one is also making sure you can code all the revenue and costs, even with FEMA grants to these departments, right? There's a major, folks do not want to duplicate not only the CARES funding, but the grants funding that's coming in. It's coming in from all parts of the hospital, perhaps, and hard to tally up. And these cost centers will help that appropriation because those costs, might not need to sit all in one department. They might need to be appropriated. And so it's important to have these set up. The other thing is we do have hospitals, like Robert just had mentioned, that have some experience in this area. Hurricane Katrina out here in California, we've had earthquakes. When I was living in New Jersey, we had earthquakes. So it's, there are lessons learned. You start getting questions about what to expect. I would expect a lot of the same in that regard. PPE and the allocation of PPE is also a topic. Most of, the recommendation is to have it sit in bulk, I should say, and then allocate depending on its use. But that's something that hospitals have certainly been talking about as they set up these new departments. Robert, you want to take it away on cost reporting, sir?
Yeah, thanks, Fred. So we're going to shift gears here, no pun intended, to the impact on Medicare cost reporting. Right? So now that we've received this funding now, and also we're tracking all these expenses, and also the different types of expenses that we may have with like telehealth and so forth. How do we account for these? And then what are the other impacts that we need to be concerned about with the Medicare cost report, or even reimbursement within the Medicare cost report? So the first one is the funding, right? So we have funding from various sources, whether we're going to get it from FEMA, other sources, through the Paycheck Protection Program, or through the CARES Act and the provider relief funding. So under the terms and conditions, right, they talked about that while you're accepting this money, that it's not reimbursement. You're not obtaining reimbursement from other sources that are also obligated to reimburse. But with our cost-based reimbursed facilities, such as critical access hospitals and rural health clinics, payment is not based on on charges and through a prospective payment system. It's based on the activity of the expenses, right? And the Medicare share is just based on the activity of Medicare volume during that specific cost report year. So if Medicare is reimbursing for expenses to critical access hospitals and RHCs, is this provider relief funding or other programs considered duplicative? The answer to that is we don't know. It appears that it could be interpreted that way. I think the intent of Congress is not to take away money from our rural providers who are already on thin margins. But, and I did pose this question to the HFMA community as well. And I did get one response that said that they're hearing that this specific question will be addressed by HHS or CMS within the near future, because that is a great question. So it may be with some, there is no offset like with the relief funding, but maybe the Paycheck Protection Program for those eligible hospitals, right? You had not many hospitals were eligible. It had to be under 500 employees. And there was if the exception was a certain dollar amount with net revenue. So, but this will be something that we're going to closely monitor in the near future with respect to how to treat this funding revenue. Is it a grant? If it's a grant, then it's not subject to offset. So other considerations, right, for those that are teaching facilities. So there were some waivers and flexibilities with respect to claiming residents. So for example, if a resident went to an alternate location, like they did the service within their own home, so using telehealth, for example, right, not necessarily video, but maybe through the telephone, or they actually went to the patient's home. Can you claim that residence time? Yes, you can claim the residence time in those alternate locations. Before the pandemic, right, it was based on there are certain requirements, right? It had to be within the hospital, or if it was a non-hospital, then you had to incur the resident salaries, right? Certain requirements. What about if they're going to another teaching hospital or a non-teaching hospital? A resident is going, can you claim the time? And yes, but all three of these conditions need to be met. So the training was in lieu of training at the teaching hospital, and it was related to in response to COVID-19. I forgot to mention that. And that training time was including in the teaching hospital's cost report. And then also that FTE count for that resident was included in the hospital's cost report prior to and or subsequent to the public health emergency period. So only during the PHE is what we're talking about here. Also, for any surge beds that accumulated during the PHE, those are not going to be detrimental to the internal resident bed ratio, which is determines the IME calculation. So providers or teaching hospitals will be held harmless for the temporary increase in their beds during the PHE. This was released on Friday. That came out about time studies for physicians. So they're giving options, CMS is giving options with respect to time studies for physicians and allocating between provider time and hospital time, or patient professional Part B time versus hospital time, which is Part A. So under the current program, it's 1 week per month for the entire year, unless you got an exception outside of that standard. So CMS then is given these 3 options: 1 week time study for every 6 months, so at least 2 weeks per year, and it could be any 2 weeks, as long as you have 1 week in a 6-month time frame. Or if you completed time studies prior to the public health emergency effective date of January 27th, then you can just use those time studies, and you're not required to have time studies for the remainder of the period. Excuse me. Or if you didn't have any time studies, you can use the same information from calendar year 2019. So this is be interesting, and when the recommendation is, if you're going to turn this off, and sometimes it might be hard to turn it back on. So just be careful if you go to these options, especially going to a 1 week time study. If operations aren't being affected, then you may want to continue with the 1 week per month. So just a bit of advisement on that situation.
Thank you, Robert. We're getting close here, everybody, just so you know, so we hopefully have enough time for some more Q&A. Wanted to just cover some other things that are listed in CMS's waivers and flexibilities. And, I don't know who's been on the CMS website. There is so much content under COVID-19. We've been certainly reviewing it, and what what I'll say is there might be things within all of that content that might be a little bit more specific to some folks. And if you want to dive into any of that, please let me know. What we've pulled here are some things that we think are significant with the waivers and flexibilities, and I'm going to go through these right now. So one is the hospitals obviously issuing temporary expansion sites and what that means. Certainly that is a cost to hospitals that needs to be considered for your quarterly reports if you had set up field sites and things of that nature. It does include things like hotels and community facilities. Provider-based outpatients are affected by that, and I'm always interested in that discussion, obviously, with recent changes on reimbursement there. Hospitals still must control and oversee operations. For critical access hospitals, you can expand over 25 beds without any negative consequence. Length of stay greater than 96 hours, and may open surge sites that are not in rural areas, regardless of location relative to any other hospitals with mileage. Subacute settings. One of the things I'll say about something I heard about this is challenging for hospitals looking to discharge acute care patients now, right? Or hopefully that's dying out a little bit. But certainly the subacute providers were not looking to take acute care patients from any reason, and it did become problematic and a cost to hospitals for that extra cost per day in that bed. So something to consider. As it relates to some of the changes with subacute settings, the 60% rule was waived during the public health emergency period. Acute care patients may be housed in some of those excluded distinct departments of psychiatric and rehab facilities. You must still bill, however, under the excluded PPS. Other considerations for Medicare cost reporting, like I just said, providing subacute inpatient services and acute beds, telehealth services, Robert went through that, and the impact of all this on your 340B eligibility. There are other issues, most definitely, that are covered. One is the definition of homebound for lab collection. Patient exercising self-quarantine are not considered to be homebound. I think that's key. For cost reporting, the relationship between hospitals and ambulatory surgery centers is always something that is interesting. And so now ambulatory surgery centers that have converted to hospitals will now be deemed to have no low Medicare utilization, and will only be required to sign a worksheet S on the cost report. In other words, it's a way that for further collaboration, which we'll see, that could be a good thing in the industry. And then there are some coding, other issues. about what to code for an inpatient or outpatient temporary site, and a condition code for practitioners and patients treated in expansion sites. And so we wanted to list all this. Again, what we're trying to do is have our resources available on our website, understanding that this is all emerging, a tremendous amount of content. Most of us on this call live in a reimbursement world, so we're identifying, well, what do we need to know so that we can do our jobs? And so from me, I want to say thank you to everybody. And I hope you're doing well, and always nice having the opportunity to connect with the provider industry.
All right, well, gentlemen, we do have a few more questions that have come in. Let's try to address those if we can. We have a question that says, how long do we need to attest to the terms and conditions? There's a time frame on those.
Robert?
Yes. Well, I was trying to interpret this question as to when we say how long, like what's the time period that the terms and conditions applies to? Is that the question?
I think that might be it, yeah.
Yeah, that's a really good question, because the terms and conditions, I don't think it specifies a time period, but it all relates to treating coronavirus, and is treating coronavirus within the PHE. It started January 27th. There is no end date, at least nothing's been established at this point. So I think it's safe to say that the terms and conditions relate to while we're under the PHE and as it relates to treating the coronavirus.
Okay, great.
Until we hear further information.
Have telehealth funds been distributed to providers? We submitted our application last month.
I haven't. There's only been a few providers that have actually been awarded the money. I don't know if they've been, and none of them are any that we're close to. So that's a good question. I don't have an answer to that. But if you've been awarded the application, and there's 6 releases that are out there on the telehealth on the FCC site, if you're listed, I assume that you'll be receiving your distribution, if not already received, soon.
Yeah, and since we're doing questions, guys, I just want to say I'm looking at friends who are sending me some notes. The portal to attest for high impact payments is open, so I just want to clarify that.
It is open, okay.
Thank you.
All right. Are there any other questions folks would like to ask? Oh, looks like we've got a couple more here. Can you explain a little bit more on the DISH money? Is CMS going to use DISH funding for COVID funding and taking away from the regular DISH funding?
I'm happy, Robert, and you want to chime in too. I'll take the first part. From what we've seen so far, I think that the remaining allocations are certainly TBD. I think we could all guess that there's a lot of advocates out in our world that are making cases for why clusters of the areas and types of hospitals need money. What we do know is what was used, and like I say, it's primarily I get very close when I'm able to pull the actual payments out of the cost report to do a pro rata allocation just for the 395 hospitals. I get pretty darn close, and the reason I say that is because I have a couple of cases I'm able to back into. I'm not exact, but I'm within 3. Robert, I don't know if you have anything else.
No, I have nothing other than that. I think still unknown at this point.
All right. We have a question. Should you only submit your 2018 or your 2019 990 form?
Yeah, in the FAQ documents, it says submit your latest one. So in this case, if you've submitted your 2019 tax return, I would submit that on the within the portal. And if that's going to be the basis of future allocation, I'm assuming the 2019 990 net patient revenue is higher than 2018, so that would be to your advantage.
All right, and then we have a question about professional groups. So a little outside of what we were talking today, hospitals, but certainly a group that's affected. I was wondering what we need to submit the HHS funds for the professional groups. We submitted the losses using revenues already.
Yeah, that's the information that needed to be provided, as well as the revenue information, the net patient revenue, because they didn't have that information. So should be another round of funding if you have not already received it. You know, they're processing these in batches every Wednesday. So it depends on the timing of when you submitted your attestation with the net patient revenue information, which would be from your tax return or audited financials, and then which is going to be the basis of the general allocation. Then the losses information, that's just information that they're gathering right now that may be used in future distributions.
All right, thank you, folks. I think that's all we have. So there's nothing else. Any other comments, Fred or Robert?
I would just say, you know, like we're reiterating, we're creating a space on our website so folks can we're trying, you know, understanding there's so much scattered information. We're trying to, you know, get it all in one spot, organized for folks. So feel free to, you know, visit our site. We're also doing some cool stuff with, you're able to kind of take a look at the funding on a map using some business intelligence. So, you know, we're moving and trying to help. And again, really appreciate, you know, we're getting a lot of feedback from the folks on this call that enable us to have these calls. Without you guys, we wouldn't have the insight. So it's much appreciated.
Yeah, same here. You know, this situation is so fluid. There's new information that's coming out all the time. I mentioned about the rural health clinic that's attached to a urban hospital. So that same client that had a situation, they just got a rural payment today. So I'm trying to reconcile what that rural payment relates to. It does say stimulus on their bank statement. It doesn't meet the calculation that's on the HHS website for the rural allocation, so it's much smaller. So these are some of the things that we're trying to reconcile, determine how this payment was made, if there's more information that's been published by HHS, and then also share that word with everyone through our website.
Great stuff. All right. Well, thank you, everyone. That concludes our webinar for today. We'd appreciate your feedback on a survey that we're going to send out. We'll let you know when our material also is posted on our website. Thank you all for attending today's session of Toyon University. Have a great day.